Registrar at Prostate University in Cape Town. He will be presenting on active surveillance prostate cancer. Who is the right patient?
Good morning, everybody. Can you all hear me?
Yes.
Thanks, Sam. So yeah, this morning we're going to shift the gears a bit. My name is Bhavin Patel, and I'm going to be speaking on active surveillance and actually who is the right patient for this sort of treatment modality. So from doing something to literally doing nothing about a patient or following up on a patient. Just start a bit on statistics. So from GlobalCan 2020 and in all males in 2020 in South Africa, prostate cancer featured as the most common cancer at 25.8% amongst all men in all age groups. The natural history of prostate cancer. So this is sort of to highlight what would happen with prostate cancer. And one interesting article is from Sacher et al. In 1994, where they did autopsy studies of patients who had died from other causes and were looking for, the likelihood of harboring microfoci of prostate cancer. And their findings were that in men who were in their 30s, 30% of patients had microfoci of prostate cancer. And when you get to your 80s, 80% of these patients have microfoci of prostate cancer, which means that this is a cancer that probably doesn't need treatment, and patients, that's where it all started from. And then the private study, sort of a prospective randomized trial, which had divided its patients into two arms, the radical prostatectomy and observation group, recruited 731. There is a lot of debate around this study and a lot of pluses and minuses, but more importantly was that there was no difference in overall all prostate cancer specific mortality amongst the two treatment arms. And this was a study from 2012. So this is the basis of sort of offering active surveillance. And just to sort of give a flow diagram, so from the prostate biopsy where you've actually diagnosed cancer, now you risk stratify or stage your patients into localized prostate cancer, locally advanced prostate cancer, and metastatic prostate cancer. And when we compare it to the patients that we are going to be dealing with in active surveillance, are the patients who've got localized prostate cancer, and part of the active management is active surveillance, radical prostatectomy, or external beam radiotherapy. And then for those who are not fit for active management, you can offer them watchful waiting. And that's where the active surveillance sort of fits in. The differences between active surveillance and watchful waiting. So active surveillance is active management with curative intent. It has a predefined schedule, and you use markers at various intervals to see if the disease is progressing. In active surveillance, you do a DRE exam, PSA, MPMRI, and rebiopsy, which are things that followed up on a scheduled basis. And these are usually offered to patients who have a life expectancy of more than 10 years. And the main aim is to minimize treatment-related toxicity without compromising survival. Whereas if you look at watchful waiting, the treatment intent is palliative, and the follow-up is patient-specific, and there's no predefined markers that one uses. And this is usually offered to patients who have a life expectancy of less than 10 years. And again, it's used to minimize treatment-related toxicity. So the data that's out there in terms of how good active surveillance, one of the good studies is from Memorial Sloan Kettering Cancer Center. And this is the long-term outcomes over 15 years of patients. So they had a cohort of about 2,900, of which 2,664 of their patients were grade group 1 patients. And over 10 years, the metastatic rate was 0.6% and 1.5 at 15 years. And the graph on this side, so the blue line shows grade progression and the orange line shows the treatment rate. So at 15 years, about 41% of their patients had progression, but the good part was that most of them did not end up metastatic. And this is good because you are sort of trying to avoid the prolonged life, but try and avoid treatment-related toxicity, but also ensure survival. So I tried to divide selecting the patients, and we'll start by talking about a few patient factors that maybe might decide where you're going to put your patient or which patients you'll actually consider for active surveillance. The obvious salient points would be a patient needs to have a more than 10-year survival, and common nomograms that are used, we would use the Charlson's comorbidity index. And if you're thinking about a patient who's between 70 and 79, the comorbidity index is already 3, which already says that the chances of surviving the next 10 years is quite low. If you start adding more comorbidities like COPDs, myocardial infarction, then that even becomes a bigger number, and the chance of surviving to 10 years is definitely reduced. These patients need to be well informed and counseled on the plans for active management, active surveillance, and they need to be motivated and compliant to their follow-up, which is very important because you have predefined intervals of seeing these patients and doing different markers and tests. And if they fall off from this compliance, then you're likely to lose them and they might progress if they're not caught up early. Is there anything else you'd consider in a patient? So when we're doing biopsies, we do consider about patients being high risk. Are this the same patients you would then think about, in terms of active surveillance? So a younger patient who's less than 60 years being diagnosed with prostate cancer. Sorry, I'm just going to ask everybody to mute their mics just for everybody else's purposes. Family history. So if somebody has a family history of prostate cancer, does race affect enrolling patients onto a program, an active surveillance program? And then there's new data suggesting BMI having an effect. We'll go through a few papers in regards to this matters that I've raised. We're starting off with young man. This is an article from 2019, which shows that active surveillance is safe for young men who are less than 60 years. It had enrolled 417 men who were less than 60 and 1,667 men who were more than 60 years on their active surveillance program. And the median follow-up was about 6.2. Important to note was that there was no difference in the treatment rates. So all the patients got their treatments, and actually freedom from treatment, the cancer-specific survival was sort of similar. What does this offer? It's sort of the idea behind offering a young man active surveillance is that they're presumed to be at greater risk of sexual side effects. And if you think about it, a patient who's at 50 and 70, it's sort of presumed that the patient at 50 will have a bigger impact if they end up with sexual related side effects from radical treatment, be it radiotherapy or radical prostatectomy. And it is found that in this group of men, most of them have low-grade tumors. The only issue is that if you expect your patient to live more than 30 years, then currently we do not have a 30-year follow-up data, and therefore we cannot, or to be honest to the patient, you cannot say that there is good evidence for it for them not to progress, but they can still be enrolled for an active surveillance program. History of prostate cancer in the family and active surveillance. This is again a systematic review that had about 6 studies that were good powered, and it basically did not show any difference. And here we're talking of family history of prostate cancer. It does not appear to have an increased risk of having more aggressive cancer, and therefore not an absolute contraindication to enrolling somebody for active surveillance. The only issue that I'd like to raise here is that we're not talking about the BRCA mutations here. Those have a multiple hallmarks for aggressive disease. And if you have a BRCA mutation, even if it's a Gleason 3 or grade group 1 histology, it is sort of thought to be a more aggressive type of cancer in the same setting as a Gleason 4 or 5. And we'll talk about this a bit later. Race. So there is the concept of, having the African American race or the Black man having a more aggressive disease. And if you look at, or if I went through the 2 papers, one is a systematic review and one is looking at association between African American and clinical outcomes for low risk prostate cancer. They do note that there is high rates of progression and patients do end up with getting their treatment compared to their other counterparts, which were being compared, usually the Caucasian cohort. But of note is that there's no difference in metastasis or mortality, and therefore you can offer patients of the African American background active surveillance, but you need to sort of inform them that they might have higher rates of progression and treatment, and therefore maybe they will need closer monitoring and follow-up for their active surveillance. Interesting article that I came across from the New England Journal of Medicine about obesity, immunity, and cancer. And they sort of say that obesity induces a metabolic tug of war between the tumor cells and the T cells for lipids. And therefore, when the tumor cells take up the fatty acids, which are then partitioned within the tumor. And the idea is that the fatty acids, the CD T cells are sort of deprived of the fatty acids, and this leads to reduction in the T cell or immune function of that. And just to support this idea, there's an article that showed association of periprostatic fat and grade group progression in men with localized prostate cancer. So on the MRI, they had divided patients into tertiles, so 3 different groups with sort of low periprostatic fat, intermediate periprostatic fat, and high or huge amount of periprostatic fat. And they had 175 men assessed who were already on their active surveillance program. And it was shown that those who had a periprostatic fat volume was associated with increased rate of grade progression with a risk of 2.6. So another article that sort of is important to note here is the impact of biopsy compliance on outcomes for patients on active surveillance. This is just to sort of highlight how important it is at the outset to tell the patients who you're going to enroll for active surveillance on their compliance to follow up, and especially to biopsy. This is one of the things that patients generally do not like or approve and would try and avoid, but if they do not get their biopsies, they're likely to end up with poorer oncologic outcomes as demonstrated by this graph here. Moving on, what are the pathological factors that you would sort of consider for a patient you want to enroll for active surveillance? And if you look at the different guidelines, they sort of risk stratify localized prostate cancer. The EAU classifies into low, intermediate, and high risk, whereas the NCCN sort of subclassifies the low into very low and low, and then the intermediate group has been again subclassified into favorable and unfavorable. Generally, the parameters that are looked into are the PSA, which is less than 10, between 10 and 20, and then the high risk more than 20. And then you have the Gleason grade less than 7, 7 more than 7 for low, intermediate, and highs. And then when you're looking at the PR or digital rectal exam results, low risk would be considered at less than 2A, intermediate at T2B, and high at T2C. And sort of where the active surveillance is offered is between the low risk mainly, and then in the last few years, the intermediate group has been taken onto the active surveillance program, which is a matter of debate, and there's a lot of stuff on it which we can discuss a bit later. So enrolling patients for active surveillance, these are all the different studies that have sort of taken up patients, and you can see that it's sort of a heterogeneous criteria for taking patients. Not everybody has similar criteria for enrolling patients onto the active surveillance program. Some would enroll at T1C and others would enroll at T2A. Most of them would enroll patients who've got a Gleason 6 and less. Only a few studies here would have the intermediate risk prostate cancer patients. And again, prostate core, the number and the percentage is of importance. And also, 2 of the studies use the PSA density, which is one of the factors that you should consider when you're offering a patient active surveillance. So from the different protocols here, you can see that some of them have stricter class criteria to enroll a patient, and that's probably the Epstein criteria that you're looking into there. This is a very more sort of liberal enrollment scheme. And does that make a difference? Does that sort of, will the stricter criteria have less progression than the ones who have more open criteria? And this is one of the studies that was sort of looking into this, and they, compared all the different criteria and found no significant difference for upgrading or biochemical failure after treatment for any of those criteria that are used. This is sort of interesting, and I just wanted to spend a few minutes talking about it, was that it's actually from Campbell's, and it's comparing the Gleason 3 pathology versus the Gleason 4 pathology and what they sit of in terms of hallmarks for cancer. And it compares very well what Gleason 3 cancers are, and it's usually thought that the Gleason 3 cancers are indolent cancers in that they have a very, very low potential for metastasis, and that's why they're good cancers to offer active surveillance for. And when you start speaking about Gleason 4, these are cancers that have a probability of metastatizing and actually progressing, and therefore you need to be a bit more careful about that. So when you look at markers of proliferation, you can see that the Gleason 3 cancers don't have that, whereas the Gleason 4 are overexpressed or aberrant markers. And when you're looking at the hallmarks for cancer, so markers for tissue invasion and metastasis, in Gleason 3 it's normal, whereas in Gleason 4 it's overexpressed. insensitivity to growth inhibitory signals. Gleason 3 expresses that, whereas Gleason 4 is absent. Resistance to apoptosis, Gleason 3 negative, Gleason 4 strong expression. VGF, microvessel density, proangiogenic factors, Gleason 3 low expression, Gleason 4 increased expression. Metabolic pathways, again, Gleason 4 shows presence, whereas Gleason 3 shows absence. Absence of senescence, which means that the cells will not die, and this is, again, another hallmark of cancer. Gleason 4 sort of demonstrates an increased absence of senescence, whereas Gleason 3 is just normal. Changes in the PTEN gene. The PTEN is available, is shown to be present in 90% of the Gleason 3, whereas it is deleted in 70 to 90% in Gleason 4. And then clinical evidence of metastasis and prostate cancer mortality after surgical grading is absent in Gleason 3 and Gleason 4. And then just to think about it, then why would you sort of have this stricter criteria and just say very little of Gleason 6? Even if you're looking at it, why would you not, offer active surveillance to patients who've got, let's say, about 4 cores? So the general idea is not that because at 4 your Gleason 6 is likely to metastasize, but it's based on the fact that if you've got a higher burden of Gleason 6 cancer, then it's thought that you're probably harboring a higher grade of cancer, and that's the reason of sort of sticking to the lower group for active surveillance. And then just to look at the intermediate risk group patients and the different guidelines. So the EAU sort of has given a go ahead with low risk sort of active surveillance should be discussed with low risk patients, as well as selected intermediate risk patients with favorable grade group 2 lesions. The NICE guidelines also say active surveillance might be a safe option for some people with intermediate risk localized prostate cancer. The NCCN guidelines also in support of that. The AUA sort of is in support and sort of says that you should select patients with favorable intermediate risk cancers. So not everybody with an intermediate risk cancer becomes a candidate for active surveillance, but then how do you decide this? And if you look at some of the studies, this is one good study, which is the PROTECT study, and it had a 10-year outcome and had patients divided in 3 arms. That's monitoring, so active monitoring, which is a different term that was used 10 years ago compared to active surveillance. It's definitely not the same stuff. And then patients were randomized to surgery and radiotherapy. And you can see that over time, the active monitoring group had received intervention. But what's important is the graph here, where this is cancer-specific survival, and all the 3 had no sort of, progression or did not affect their cancer-specific survival. And of note is that 21% of patients in this, on the active monitoring group, had a Gleason 7 pathology. So looking at Gleason's 3+4 or Gleason 7, why would you not offer a patient with Gleason 4+3 in comparison to a 3+7, 3+4 pathology? So if you look at the graph here, and this is an article from the EAU sort of journal, the patients who had a Gleason 6, and then if you look at the ones that had a Gleason 3+4, they have a sort of similar recurrence-free survival. But as soon as you take that to be a Gleason 4+3, then there's a big, vast difference. And that's why this is sort of thought to be around the same area. And if you sub-stratify that, the Gleason 3+4, and take it into the next sort of 10%, 5%, which is what the guidelines sit at, most of them would say that if you're going to enroll somebody on the intermediate risk, then the tumor burden should be between 5 and 10% for most of the guidelines. Then you can clearly see that it's almost sort of following the Gleason 6 pathway. And as soon as your tumor burden increases or the burden on the cores increase, then your survival free or recurrence free survival is affected drastically. So is it okay to then look at just the percentage? One of the new thoughts around this is when you say 5% in a core that's 2 centimeters long versus 5% in a core that's 1.5 centimeters long, it surely isn't the same tumor amount. And therefore, somebody then ended up looking at rather the length of tumor that's involved. And this is the clinical usefulness of total length of Gleason 7 in biopsy in patients who've got grade group 2 cancer. And the take-home message was that do not look at the percentage involvement without knowing the core length. And that's basically because if you look at the graph here, you've got that as the length of the Gleason 4 on biopsy increases, the probability of adverse pathology increases. And if you're going to offer somebody active surveillance, you want to sort of have them having a similar risk as a grade 6 cancer. And if you draw a line where that sits with a grade 6 or ISO grade group 1 cohort, then you're likely to end up with a tumor that's about 1 millimeter in size. And that's what some of the units are actually offering, where you would be enrolled on an active surveillance program if your tumor length on a core biopsy was less than or equal to 1 millimeter. More importantly is then looking deeper onto the pathology aspect, and the Gleason grade 4 is a heterogeneous disease, and it's got 4 histological types, of which one of the types is the cribriform type, which is associated with more sort of adverse outcomes. So if you look at if you again risk stratify patients who have Gleason 3+4 into the cribriform or intraductal carcinoma negative or positive, and sort of draw a graph against it, those who had the cribriform pattern had a poorer outcome with metastasis-free survival as those compared to that. And some of the sort of new guidelines are now sort of thinking about including this as one of the criteria that one would have to look into. So if you had a biopsy that showed a Gleason 3+4, then you again ask yourself, does the patient have cribriform or intraductal carcinoma present? If they do, then they're not eligible for active surveillance. If they don't have cribriform, there's still a chance that the core that was taken missed the cribriform sort of pathology, and then you need to sort of again use other markers to figure out if this patient would fit well. And some of the adjuncts that are coming across are actually MRI. So the MRI, as we know from the Precision trial, has sort of reduced 50% grade group 1 detection on the biopsy, and therefore reduced. If you look at it on the terms of active surveillance, that helps with sort of putting the MRI into the place where it can be used as a marker or as a tool for deciding which patients can be followed up on active surveillance. And then MRI followed by selected targeted biopsy is non-inferior to initial systematic biopsy, and it's less likely to miss undetected grade group 2 lesions, which are less likely to progress or become metastatic. It's important to note that when you have a positive MRI, then it's associated with higher rates of adverse pathology and upgrading. And when you go back to this, when you look at that and you've got no cribriform, but you've got a positive MRI, then some of the people would actually not offer active surveillance to this group of people. Talking a bit about germline mutations, that's the BRCA and the ATM, these are associated with higher risk of reclassification on men in active surveillance. And this is a study which had 2 independent cohorts who are undergoing active surveillance. And the germline mutations formed about 2% of the overall carrier rates. And again, it showed an association of more aggressive phenotype, though the numbers are limited in that, and it's hard to sort of draw conclusions, but you can see that over 10-year follow-up period, the incidence of having progression was higher with patients who had a BRCA versus non-mutant carriers, or patients who had no mutation and they had then the germline mutations. So it is something that will probably come into play or will be taken into consideration in the near future. And then just using genomic tests as a predictor of adverse pathology, this is one of the sort of studies that I came across, and the take-home message was that at the current setting, there's no association with upgrading on surveillance biopsy, and therefore it's probably not a good test to offer for patients you're going to have on active surveillance. And that's my talk. Thank you.
Yeah, thanks a lot, Bhavin, for an excellent talk and an overview on active surveillance. Let's see if Prof has got a question. I'll just let him start. I'll follow when he's done. Thanks, Prof.
Bhavin, congratulations. I think that's a wonderful start to the what a careful deep dive into the literature you've done there. So thank you very much, Bhavin. in the new journal, the African Urology, that we've just started publishing, there's an article about robotic prostatectomy in our town, and it's been pointed out that 50% of the cases were Gleason grade 1 who underwent prostatectomy in that series. How do you think we can popularize the idea of active surveillance more fully in our community? What do you think are the impediments to uptake of active surveillance amongst our community colleagues?
Well, I think the idea is actually to have patients or have a criteria that you can put out so that people can have an idea of where it's going to be, which patients to enroll for it. And there is good data that shows that patients who are put on active surveillance, especially with those who've got a grade group 1 pathology, they do not end up with progression of the disease, so long as you stick to the guidelines, and so long as you've got a good selection of your patients, then you're likely not to end up. And this is probably, I would say, to have a better uptake, it's maybe just ongoing education and ongoing sort of, having data that probably can be published locally, especially from tertiary institutions, that would sort of, help people make these decisions. I don't know if that answers your question well, Prof, but that's what I would sort of think in terms of helping increase the number of active surveillance in the country.
Thanks, Bhavin. Excellent presentation.
Thanks, Prof.
Justin?
Yeah, hi, Bhavin. Did you come across anything regarding PSMA PET scanning and active surveillance? We've noticed certainly in patients who've done PSMA PET scans that you're often finding a lesion outside the prostate in the node. Would that help us classify these patients?
Thanks, Justin, for that question. I, in my reading, haven't come across it. I think right now the new toy is the MRI, which everybody's playing with in terms of the biopsy and localized prostate cancer. So I don't have any articles I can quote on that. I would have probably put it up if I came across something like that. But yeah, no, unless you have something to share, Justin.
Yeah, thanks, Bhavin. I actually wanted to ask you the same thing that you just mentioned. So, Justin, do you have something to say following up your question?
No, I haven't come across it either, but it's an intriguing thought.
Great. So, a very intriguing thought, especially if you can show a node outside, then you're probably not a good candidate for active surveillance.
So just a follow-up question on what you just said, Bhavin. How do you incorporate a multi-parametric MRI in super selecting patients for active surveillance?
Thanks, Sam. Just try and pull that slide up. So it's basically an adjunct to everything else we've said. It's more likely to be used in patients who you're thinking of with an intermediate risk group cancer that you'd want to sort of have an MRI. And it depends on what pathology your patient has. So if they've got, Gleason grade group 3 and you're still worried about cribriform, and you look at it, then if they still have a positive MRI, the data there says that there's high rates of adverse pathology and upgrading. So these are patients then that become more sort of high risk in active surveillance, and you'd want to follow them up closer. And if your biopsy protocols say between 12 to 24 months, some of them will actually be offered a biopsy much earlier, at let's say 12 months, to re-stratify them rather than waiting till up to 24 months. That's what I would think.
Yeah, I think you're quite right. I mean, I agree with you. It's an adjunct, and that's why most literature is really moving forward, getting an MRI before doing a biopsy, so you can really, put patients where they belong if there are no adverse pathology on the MRI. And the reason why I'm asking you this was we recently had a patient, combined uro-oncology clinic, who had a Gleason 3+3 on a fusion biopsy, but the MRI showed an equivocal SV invasion. So what do you do in a patient like that? Who's got 3+3, but there's some query SV invasion. So I think you're quite right. I mean, it is an adjunct. I don't know, do you have anything to say on that?
from one of the talks I listened on the EAU, actually, if you've got SV invasion, that then technically becomes a T3 cancer. And then that's not a patient you'd offer active surveillance for, in my opinion. And there was a patient that was presented on one of the meetings with that sort of, similar histology on the core biopsy, where they saw a small focus of Gleason 3+3, and he had a Gleason 3+4 on his main core, and the 3+3 was in his SV. And I think there was a similar feeling that this patient wasn't a candidate for active surveillance on the same talk.
Thanks, Dr. Colley. Your question?
Hi, thank you very much, Sam, and good morning to everybody. And once again, a great talk by Dr. Patel. I think the first thing I just wanted to make a comment around what Prof was asking initially, Prof Lazarus. I think one of the problems we have is we often hear about how well patients do, after radical or after brachytherapy, but I don't think we often hear enough about patients that have been put on active surveillance and have done well. And this kind of brings me to really the question I want to ask, and I may have missed it maybe in Dr. Patel's presentation, but how long, do you surveil these patients? We know roughly when we talk about screening that we'll screen between these ages, and when we get to a certain age, maybe it might be okay to stop. When you have a patient on active surveillance, do you have an idea about how long you continue with this, or is it for life?
Dr. Patel?
Sorry for that. I was just trying to get my mic on again. Thanks, Dr. Goli. I think most of the data that I have from the big trials have their patients on 20 years surveillance. And that's why I was sort of, highlighting on whether, you'd put a very young patient on active surveillance, and would it be safe for, let's say, somebody who's less than 60 and you expect them to live up to 80 years, would you then offer them active surveillance? There is no obvious data that goes more than 30 years, but they do sort of say that in some of the studies that after 15 years, if you've surveilled somebody for 15 years, the chances of you progressing after that is much, much lower. So it's probably based on that you can offer a young person active surveillance, and maybe after 15 years, you can sort of relax on that. And again, it's at the outset that you probably want to set rules that, look, if you get to a point where your life expectancy is less than 10 years, then you're probably going to become a candidate for watchful waiting. And the whole idea behind active surveillance is actually to minimize treatment-related toxicity without compromising survival. So the minute it becomes opposite, where your survival is deemed, less than 10 years, then maybe the idea would be to try and just minimize treatment-related toxicity. But I think at that stage, you would have achieved your goal in trying to get this patient not to have treatment-related toxicity. I don't know if that's a comprehensive answer.
Yeah, thanks. Thanks, Bhavin. Just a quick question there on the chat. I don't know if you can see that. How well does literature correlate African men versus African American men? Can you use that data from African American men, South African men?
Yeah, look, I think it's a bit, when it comes to stratifying patients based on race, one of the things that, some of the articles state is, one, it's what the patient who identifies themselves as. So they're probably patients who identify themselves as African American, but they have mixed genetics in them. And then there's the idea of having access to healthcare. We do know, like, if you're going to talk about the South African cohort or African cohort for that matter, you might have patients who have, better access to healthcare versus others. So there are a lot of confounders for you to sort of, generalize these things. And it's one of the reasons why we don't have a pinpoint or finger on whether there is actually, data to support that we have a more aggressive disease compared to the normal Caucasian cohort, or whether there's actually just other confounders that, make our cohort present late to the clinics or to the healthcare.
Question from Lisa, thank you.
Hi, Sam. Morning. It's not a question, it's just maybe a comment. So this this point of race, genetics versus risk is quite an important question, and we've been trying for a while to get involved in some work where one is comparing or at least trying to validate tools used elsewhere for genetic risk stratification in our population as well. That hasn't really come to fruition yet, but hopefully we'll get involved in something like that in future. And I do think there is a role, or there will be a role in future, using biomarkers and metabolomic markers to try and risk stratify patients better in terms of who are candidates for active surveillance and who aren't. And I don't think we're there yet. There's so much work happening all over and locally and abroad. And I think eventually we will get there, but I think we're probably 10 years away from that. We will be able to do a panel which will predict which patients, irrespective of their Gleason, are going to behave badly and which ones can actually be safely surveilled. So I think that's all in the pipeline, and eventually we will get there. And I think there's a lot more interest into including African populations as well as populations, from the better funded countries.
Yeah, no, thanks a lot, Lisa, for that comment. I think in the interest of time, we'll have to close the session. Thank you so much to Dr. Nazreen Beam and Dr. Patel for great talks. I'll see you guys in the next week.
Thanks.